Most people, up to 90% of people, will probably have some form of back pain at some point in their life. And this can be for obviously varying reasons. Risk factors can be poor posture, repetitive trauma or stress with work, injuries, poor fitness, even aging and degenerative changes, hereditary causes. But we have to keep moving. That's what our bodies are meant to do, move. And so we wanted to kind of present to you guys some new muscle groups that maybe you're not familiar with, some guidelines that they talk about with physical activity, and then what to do if you do have back pain as far as using ancillary services such as PT and or seeking further medical intervention. So we will have some time for some questions at the end, so please feel free to ask them, and hopefully this is very informative for all of you.
Yeah, so why is movement important? Well, life requires movement, right? So everything that we do, whether that's out in the community doing social events or just day-to-day errands or being physically active for fitness and wellness, requires us to move. And our bodies are designed to move. We benefit from movement. And so when we start to limit our movement, sometimes that can create or cause pain. And so when people start experiencing painful movements, then they start to move less, and that kind of perpetuates this cycle, right? So we don't want to move because we hurt, and then we're starting to hurt more because we're not moving. And so if we can keep our bodies in motion, that is really the best way to keep us optimal with function. Hippocrates, the great Greek physician, said motion is life. And so if you think about it that way, that's pretty cool. It's kind of our source of our lifeline. And so we wanted to provide a few pieces of literature that are out there to really support specifically exercise. The American College of Sports Medicine group, which is the largest sports medicine organization in the world, came out with a position statement back in 2008 that's still current. And they recommend for most adults to engage in at least 150 minutes of moderate to intense exercise each week. And so they broke that down into 4 categories. They talked about cardiovascular training, resistance training, flexibility, and then what they say neuromotor training. And so for cardiovascular fitness, they recommend 30 to 60 minutes of moderate to intense exercise each week. Resistance training, they encourage each major muscle group to be trained at least 2 to 3 days per week. They say 10 to 15 repetitions is good to promote muscular strength, and then 15 to 20 repetitions for muscular endurance. Flexibility exercise, so that can be stretching or mobility training, is 2 to 3 days per week as well. And that can be static poses, that can be dynamic movement, what we say ballistic or oscillatory movements, yoga, 2 to 3 days per week. And then neuromotor exercise is agility training, balance training, coordination, functional movement. They also recommend 2 to 3 days per week, and that can also come from classes like yoga or even Tai Chi.
There was a recent study actually that was just in the American Journal of Epidemiology. It's from the University of Sydney, and it was actually demonstrating that strength training is just as important as cardiovascular training. I think we kind of get into the habit of, okay, I'm going to get out on my walks or cardiovascular training, which is very important obviously, but strength training is just as important, and it's been shown to actually have a reduced impact on death. And so they're showing that this does not have to be you getting a fancy gym membership and doing high level, strength resistance training. It can be just body weight supported training, squats, wall supported push-ups, tricep dips. Just getting muscles functioning and strengthened is actually really important for reducing kind of mortality. And all this study was on people ages 30 and over. So it shows you that varying what you like to do is also important. Our body gets used to whatever stresses we put on it. So if we are sedentary all the time, it's used to that. We try something, new activity, that's why it's hard to just go at it like a weekend warrior if you haven't been doing it. We like to slowly, gradually increase activity. And then we get used to that stress that's been put on it. If you're only doing cardiovascular activities, that's kind of what your body knows. If you're only doing strength training, etc., flexibility, your body is not going to respond as well because it's not used to those things. So we like gradual increases and then variance in what we're doing, because that can also just lead to proper motor control. We're going to talk a little bit more about how sometimes we think we're doing things great and our motor control is a little off, and we can kind of reset that. That's the great news. Our brains are plastic. We can learn new brain mapping in 30 days. If we're doing repetitive, good quality movement, it can change. So that's always something, and people will always ask me, oh, I can't do that, I'm over a certain age. It doesn't matter. We can form new patterns, new neuromuscular pathways through repetition and practice. And so that's why it's really important to keep moving.
So we wanted to help everybody understand neutral spine. So we've been talking about movement and exercise, but this is kind of about your back. So what is neutral spine? I don't know if that's a word people are familiar with, but I brought the model here. So a little bit in neutral, but neutral spine is the natural curvature that the spine makes when each region of the spine is in optimal alignment. So we kind of break the spine down into 3 regions. There's the cervical spine, okay, the thoracic region, and then the lumbosacral spine. And so when each region is in its optimal alignment, it creates this nice natural S-shaped curve. And so that is what we coin neutral spine. And so our bodies are designed to move from that. Each region of the spine has different amounts of movement to it that collectively help give us 3-dimensional movement. And so mechanically, the spine moves in 3 planes. So we have flexion and extension, right, forward and back bending. We have lateral flexion or side bending, and then we have rotation. And so again, each region of the spine is designed to move more in one plane over another. And so when we lose neutral spine, that can be from a particular region or all regions losing that optimal alignment, and that's when we get set up for overload of tissues or injury and pain.
Perfect. So I'm going to kind of go off of that topic and talk about some muscles that many of you might not even know exist. And these are the inner core muscles. Core strengthening is kind of a buzzword out there because we think six-pack muscles, large back muscles, and that's kind of all we really truly know when we're like, I'm going to strengthen my core. But we have a group of muscles that in healthy individuals activates without you guys even knowing it. And those muscles are, believe it or not, our breathing diaphragm. Breath control is so very, very important when it comes to pain in general, but especially back pain. It is the top, if you guys can see on one of the handouts, there's a picture that we provided of these inner core muscles, and it makes the top of this canister, the breathing diaphragm. The front of the canister is the transverse abdominis. This is underneath the six-pack type muscles. On my pregnant belly, it's a little stretched right now, but it runs laterally, and it kind of forms a corset around your spine. And then it tensions into a large fascia we have that's really important. And then we have the multifidi muscles, which is from each vertebrae. It helps with individual stability. And believe it or not, the pelvic floor, or Kegel muscles. Now guys, you all have these muscles too. My male patients are always shocked to hear that. And that forms the floor of our pelvis. The pelvic floor is not just for urinary function that most people know about. Any of my back pain, hip pain, even shoulder pain patients, I'm going to know that I'm going to see that they're using these muscles correctly. Because to be able to dissociate movement from our shoulders, from our legs, we have to have these muscles kicking in correctly or as well as possible. And these are the muscles that help us maintain that neutral spine. The pelvic floor also helps with bowel bladder function, sexual function, and as far as lymphatic kind of pump action, getting things out to our lymph system. So really important group of muscles, but again, most people haven't heard of them or addressed them. And if we're seeing a patient, we're going to see what the function is of these muscles first and see what that dynamic control for somebody is. Can they lift their leg without completely shifting? Or when they're laying down, can they lift their leg without going completely into their extensors, causing pain or problems sometimes shooting down the leg? Can we get them moving again where there's not pain? A lot of times pain creates anxiety, fear. So exactly what Merrick was talking about earlier, we stop moving. And then we don't know how to move. But unfortunately with life, we have to move. We have to take care of our kids, go to work, clean our house, do whatever, and that requires movement, but then we get fearful of it. And so we want to make sure before we train the global muscles that everybody knows about, the six-pack type muscles or the larger muscles, the hip muscles. We want to make sure these foundational muscles are working correctly, that people can breathe correctly, they're not holding their breath unless it's something that needs to happen. We want to just make sure that the function and quality is correct. So having an awareness that these muscles even exist is the first step. Because when you go to the gym next, I guarantee all of you will watch, and you'll see that person who might have something that's a bit too heavy for them. And they're going, and as they do it, they can't do it without their back going like this. Or they're not actually feeling it in the glute where they're supposed to be feeling it. They're like, my back is killing me by doing this leg extension exercise. But it's because either the load is too great for what they're doing, or their muscles aren't kicking in for them how they need them to. And that might be where they might need some motor retraining. The great news, again, all of these muscles can be retrained, and sometimes they can turn off or become more muted for different reasons. So surgery, childbirth, even hormonal changes as we go. When we don't have the ovaries producing estrogen, the pelvic floor muscles actually are really, they like estrogen. And so all of these things can come into play when we're working with our core muscles. It's not normally just one thing. We kind of have to take everything into play. Pain can actually inhibit these muscles. I know, so even myself, a couple weeks ago I had a strain with all my new relaxant in my body from being pregnant, and I am an expert in trying to find these muscles and teaching people how, and for a day I literally could not find the muscle because my back muscles were in such spasm. And so I had to keep repetitively doing it, and it turned right back on. But you can see how people who don't have an awareness of this would have no clue of that function. And then they keep going on their daily life. And we might be able to do that for 30 years, no problem. And then one little thing, I'm leaning over to grab something off the floor, horrible pain, and it's kind of this cycle. So that's where we like to just give that education. These muscles exist, and being aware of them, and if you need help finding them, that's where kind of physical therapy can come into play.
Yeah. So what is physical therapy? Most people probably have a good idea. Physical therapy is a treatment approach to treating dysfunction or diagnoses or pain through physical methods. So we are one of the movement specialists in the medical field, and so we kind of identify neuromusculoskeletal systems and identify how people are moving, and looking at all the layers of the body, the fascial layer, the nervous system, the musculoskeletal system, and identifying how people are moving in a way that is either contributing to pain or in a way that's not optimal. So we can provide, like Morgan said, a lot of awareness, tons of education, certainly corrective exercises, a lot of hands-on soft tissue mobilization to get you back to your optimal function. It's usually not a quick fix, so sometimes that's a little bit of a challenge, but we like to think that we can provide that buy-in pretty quickly for patients, learning a lot of good information and just getting their bodies moving again.
So if we had a patient come in and we did our assessment and we were finding kind of where their functional tasks that they're having the most problem, and then we've looked at their motor control and strength, and we start dealing with pain management and things like that, but they're plateauing, they're not getting there, or we can't even get to the strength training component of things because the pain is limiting them. That, or there's red flags as far as bowel and bladder changes, lancinating pain, or electrical type pain, things like that. If they don't already have orthopedics on board, then we're definitely going to make sure orthopedics is on board, because that's where that interdisciplinary care can really give the best options for our patients. So with that, I'm going to turn it over to Dr. Smith so he can kind of talk about his side of things.
Welcome, everyone. There's some familiar faces in the crowd. So obviously it's never ideal to come in and see a spine surgeon. And there are some myths, and there's also some bad track records out there. And ultimately the spine has two functions, and that's to keep the body upright, as they were saying, alignment, which is incredibly important, and protect the nerves. And so the things that concern me, the red flags, the lancing radicular pain, that's totally one. If there's any weakness, worsening alignment, and balance or hand coordination issues, or bowel or bladder. Those are all findings that can become permanent, and that's a concern because the spine's no longer doing the function that it needs to. And if therapy, in regards to physical therapy, isn't able to modify those, when it comes to weakness, you have about 6 months before it may be permanent. And so, just a little overview of my talk. We'll talk about low back pain and leg pain. We really won't focus on the cervical spine today. We'll talk about some minimally invasive surgery, and then we'll talk about when that's not an indication. There's alphabet soup. I don't know if you guys are familiar with all the different nomenclature of all the different implants and fusion devices, but if we have time, we'll briefly go over those. And so chronic back pain affects 1 out of 10, and it's very, very common. If you look at the cost, it's upwards of $100 billion per year, and that was as of 1991. And as of 2010, it's gone up to $560 to $636 billion per year. It's a behemoth in regards to what we put our GDP towards. And so preventative medicine is huge. If there's things that you can do to avert surgery in a safe manner, I'm always for that. I think if you can not operate and able to maintain balance, able to maintain strength and alignment, that is going to be the best option for you. And when we talk about pain generators, that's really ultimately my biggest responsibility, is when you come into my office, I need to figure out, first of all, does your MRI match your exam? And if it does, then I need to make sure that I'm not missing anything that's scary. And then we start going from there. How can I optimize you? If you've done physical therapy, well, then there's other options, and I'll get into those. But pain can be caused from herniated discs, collapsed disc spaces, so that's more of a degenerative condition. As we age, the water within our disc is reabsorbed, and so you get loss of height. And when you have the loss of that disc height or that cushion, what ends up happening is the little nerve that leaves can get pinched, and that's where you get that radicular pain. And then deformity. We think of scoliosis as in kids, but as we age, we can develop what's called a degenerative scoliosis, and that's a big problem. The bones aren't as healthy as when we're a teenager, and patients sometimes aren't as healthy. And so non-operative treatment, we kind of started talking about physical therapy, modifying your activities. So if it hurts, don't do it. It doesn't mean don't do anything. It just means there's a reason why there's pain. And then stretching, low impact exercise. Some of my patients have benefited from acupuncture. Smoking cessation and weight reduction are huge. I am really a big proponent of getting all forms of nicotine out of our system. And the reason why is nicotine shuts down new blood vessel growth. And if you're smoking, not just, let's say, chewing tobacco, the smoking of cigarettes also increases carbon monoxide. And carbon monoxide also prevents oxygen from getting to the structures that need to heal. Even if it's something that's not surgical, we still need to give our bodies the best chance to heal. Anti-inflammatories, muscle relaxers, and then physical therapy. And physical therapy can be used for multiple adjuncts. One of the main reasons I use it is if patients have failed it, but they're not healthy enough. They talked about if you're not moving and it hurts, well then you start to decline. Well, if I'm about to do a big surgery on you, I need to make sure your heart and lungs are healthy to tolerate it. And if your body hurts from, let's say, hip arthritis or knee arthritis, well then aquatic therapy I think is huge. And it's a very valuable kind of option to where I can get your heart and lungs working, I can get you breathing and moving without having some of the arthritic pain that usually plagues us. Ice or heat, chiropractic care, and then steroid injections is kind of the next step if we're kind of starting to talk about surgery. And so I'd like to kick it back to the therapist to discuss things to optimize a patient maybe before we undergo a surgical operation.
So exactly what he said, we're going to kind of figure out where we're having trouble. So if it's we need to get your cardiovascular up, if you can tolerate land-based therapy, we're going to do that. If not, we're going to get you over to where we do have aquatic therapy, meaning pool-based therapy. We will use modalities to try to help with pain management. That modalities include ultrasound, E-stem, trigger point dry needling, even for some manual release. And we also want to try to get you moving in small ranges of motion that facilitate movement without pain. So we want to keep you moving and getting the muscles firing, foundational muscles firing as much as possible to get you strong. It's like if you go into a knee surgery, this is like any other surgery, you want your quad as strong as possible. We want you going in to optimize outcomes as strong as possible.
And so, as the name of the talk mentioned, minimally invasive surgery. And sometimes it's misunderstood that it's less surgery. It's really what it is it's less collateral damage to the structures around where we need to go. The tried and true surgery that we've been doing for years, really all minimally invasive surgery is how do we use x-rays, different instruments to safely get to that space with a smaller incision. Now once we get to that space, the work is the same. The bone work, the fusion work, whatever we're talking about, if it's a decompression or if it's a fusion. And so the first kind of surgical procedure I'll talk about is a decompression surgery. And it's called a microdiscectomy. And what that is if we have a disc that is herniated or bulged out and pushing on a nerve or pushing on the sac of nerves, then one of the options, and this is where a lot of my training came from, is using what's called a tubular dilator. And so I find the level that's affected. We'll use MRI and x-rays and sometimes even CT scans to make sure that we're at the right place. We know exactly what the pathology is. And then you can basically, under x-ray, drop one small tube and then a slightly larger tube, and you keep dilating. You spread the muscles as opposed to cutting through the muscles or destroying them. You're able to salvage a lot of the soft tissue, and then once you get down to the bone, use a microscope, and you're able to then take the disc herniation out. And as you can see, this is what they're showing. This is the herniated disc. It's sitting right next to where this nerve root is. And so you're gently able to mobilize these tissues all through a 22 millimeter incision. Where in the old days, it was 3 to 4 inches. And so I think this is a very valuable tool for patients that can benefit from this. You can treat multiple different conditions, synovial cysts, which is where the joint develops a fluid structure that can also put pressure on the nerves. Epidural lipomatosis, that's where you get a lot of extra fat basically within the canal. And then lumbar central stenosis, and that's something that as we age is more common, where we get more and more pressure, because as each of those levels shrink down, it's like a car tire doesn't have air in it, it bulges out. So you may not have a herniation, but that bulge on top of arthritis can cause narrowing. And so I talked a little bit about the size of the incision and kind of some of the nomenclature behind it. And so these are the advantages and disadvantages. As we mentioned, there's less dissection or paraspinal soft tissue. The multifidi, which we already heard, one of the important muscles that connect each vertebral level. And you can, the iliacostalis, the longissimus, and the spinalis muscles, those make up the paraspinal muscles, the big muscles right here in back that run up and down the spine. You can move quicker, decrease hospital stay, blood loss, decrease narcotic use, quick return to work and normal activities. And then you can also have less nerve root irritation compared to an open. And the disadvantages are, though, it takes a lot of these to do. And so it's important that you have a surgeon that's either been trained in them or has been doing them for years. And then during the learning curve, the patients are under surgery a little longer. And that's normal with anything, is advent of new technology. And so the results. So 90% of patients have excellent to good relief of their leg pain. And about 10% have a recurrence of a herniation. And that happens. We're not fusing the level. And so it's important to talk to patients knowing that it is something that happens. And relief of low back pain is less reliable. So surgeons were really good at treating arm and leg pain. The back pain is a more difficult, kind of multifactorial issue. And the reason I say that is it the disc that hurts? Is it the joint that hurts? Is it the muscles that have fatigued? And so I'd like to kick it back over to the therapist to maybe talk about how can we strengthen these muscles to try to prevent this from happening.
Yeah, so some of this might sound a little bit repetitive, but again, going back to these foundational muscles, first of all, turning them on, right? And turning them on without your global muscles, some of the muscles he actually just mentioned, which are the movers of your body, to keep those inhibited. So starting super basic, the buy-in is, can you do these simple exercises that are more mentally challenging than physically demanding, and getting these muscles to turn on in different positions, statically, so sitting, standing, lying down, on hands and knees. And then using those muscles, as Morgan said earlier, to induce pain-free movement now with our movers of our body, to start also changing that pain-fear cycle. And so kind of starting from that groundwork, basic, but again, mentally kind of challenging, and then moving into progressive exercises from there. So often we see, especially like postpartum women, jump right back into burpees and CrossFit and all these high intensity exercises. Their bodies are just not ready to handle yet because their core has been damage, there's been trauma to the pelvis. And so starting very foundationally and then moving progressively when and if appropriate.
And so as I mentioned also, minimally invasive surgery isn't for every condition and for every patient. And so when we start really kind of honing down on the literature, there's certain herniations that do better with a microdiscectomy versus others. And so the patients that have herniations at L4-5 or 5-1, and we're talking the two lowest levels of the spine, do better than patients that have upper lumbar. There's more stress that goes through the lumbar level, and so those are more likely to herniate. The ones higher up are usually more of a long-term chronic condition, and you kind of got to start getting concerned that the central or far lateral, those are the ones that really are sometimes more difficult to treat. And so I'll have a longer discussion with my patients that, hey, you have this condition right here, we can do a minimally invasive surgery, but there's a chance that you may not get the relief you want. And now we're also throwing on the table a possible fusion surgery. And that scares a lot of folks, and that's rightfully so. It's permanent. And even if this didn't work, a revision microdiscectomy in the literature is also an option, but how many surgeries do we want to have? And so sometimes there's a cost benefit that needs to be discussed and really looked into deeply. So we talked about revision microdiscectomies. The outcomes are the same. You have a slightly higher chance because of scar tissue to have a fluid leak. The nerves are surrounded by fluid, and if you've already had surgery, and it may have even been 10 years ago, there's distortion of your anatomy, and then there's also scar tissue. And so I talk to my patients that rate almost goes up 5 times. For a primary microdiscectomy, it's about 4%. For a revision microdiscectomy, it goes up to 25%. And so the longer you've had symptoms, the harder it is to treat. And so that's where a lot of this stuff, you don't want to neglect your body. You want to get into the therapist. You want to, try to be active. Try to start these anti-inflammatories, muscle relaxers, modifying your activity, seeing what you can do to improve your overall quality of life. And so younger patients do better than older, and part of that is because those muscles are used to being worked out and used to being in motion. Older patients with long-standing symptoms experience more delayed and incomplete relief. And so again, when we're talking about options, we just have to weigh all of the risks and benefits. And the 6-month mark, I think, is really an important kind of benchmark to realize that if your body hasn't healed, and our bodies are very resilient, the human body is amazing. And if it hasn't healed in 3 to 6 months, there's something else going on. There's something that either we're doing mechanically that's incorrect, there's some stressor that is occurring, but we really need to try to, look deeper if the body hasn't healed in over that period of time. Complications, when they do happen, and it's reported in the literature, there's wrong level surgery, there's wrong side surgery. There's an inadequate decompression that can occur. That CSF leak I told you is 4% for the primary, it's anywhere from 20 to 25% for revision. Recurrent herniation we talked about, and post-operative wound infection, and then neurovascular injury. And so if we're talking about fusion now, and here's the alphabet soup, there's what's called anterior lumbar interbody fusion. I see my mentor in the back, who's a general surgeon, Dr. Rinker. And he'd be one that would help me get access to the front of the human spine. And when we look at an ALIF, I love this surgery because one of my biggest concerns is not if there's a curvature when you look at me, but if there's a curvature when you look at me from the side, from a profile view. Our body does well if we can be within about 5 degrees forward flexion, 5 degrees extension, but when we start getting out of that cone of economy, is the term that's used, we have to start expending a lot more energy. So we go from a Prius to a diesel, and we're burning way too much energy, and you realize that you're not able to tolerate walking as far. You're not able to tolerate because you're carrying your head in front of your pelvis, you're carrying your arms in front of your pelvis, and they'll weigh you down, and it'll actually make more problems in your neck start to occur, more problems in your low back. And so there's ALIF, there's PLIF, and there's TLIF. PLIF is a posterior lumbar interbody fusion, that's where I make an incision through the back, and then there's a TLIF, which is just off to the side. And so I'll kick it back to the therapist to discuss about alignment and how can we maybe help with some of the postural muscle groups that you were mentioning.
I actually love that he said there's this zone because that's so true. When we were talking about neutral spine, I never want people to think literally there's just one spot you can be in. There is a slight zone in that neutral spine that we like to allow, but when we get out of alignment, just like he said, when we get our head forward, our core doesn't kick in very well. I mean, you can try that by blowing up a balloon. try blowing up a balloon in nice alignment where your ribs, your hips, your head are all in alignment, and then try doing it with a twist. Try doing it with your head forward. It is so much more difficult to do. And that's just something to kind of visually be like, oh, that's what's happening to my body when I'm lifting something and my head's out here and I can't connect and it goes all to my back. I'm not using my glute muscles and using proper form. So really just training people on postural alignment is probably one of the best things we can do. And it's bringing that awareness. We can't change things if we're not aware of things. And so the first time you start talking about that, okay, throughout the day, I just want you to do a check. Where are you sitting? And people will come back and go, oh my goodness, I am constantly forward, or I'm rotated, or I'm shifted to one side. But they didn't even know that, and they could have been doing that for a long time. So just getting that awareness is really, really important so that we can get people so that they're nice and stacked, their core muscles are kicking in more efficiently for them, and like he says, you get tired. You get tired quickly when your head's out like this, or you're in non-optimal positions. If you're using muscles from a lengthened state, they just don't work as well. You know, there's an optimal firing pattern by how our muscles are, and if we're in a really lengthened state, they're not going to fire as well. So even just little things throughout the day, set reminders for yourself to kind of imagine. Again, I like to think of rings just because it's easy for patients to really think about. And are those rings stacked? Are they in nice neutral alignment? Again, there is going to be a zone. We're not going to be specific. We don't walk around like this. But trying to stay so we are not putting as much load through the tissues. That's what's most important.
And we mentioned scoliosis earlier. And we also mentioned the diaphragm. Well, think of what's occurring when we have rotation and flexion of the spine. Well, that bellow or the diaphragm that's helping the lungs breathe, which is a vital part of living, if you now start rotating that diaphragm is not operating in a functional manner, and so your oxygenation decreases. Again, your ability to have cardiovascular endurance decreases. And so it's really important alignment. And in the last probably 5 to 10 years, they've really honed in on the sagittal alignment, which is the forward back posture. And so speaking of sagittal alignment, I wanted to kind of display a case presentation. This is one of my cases from a year ago, and this gal presented to me. And so this angle that I'm drawing right here, this is called a T1 pelvic angle. And I really like to show all of my patients their x-rays, really go over what's going on, what I'm concerned about. And so when looking at this x-ray, if I draw a line from the center of the sacrum, which is the bottom part of the spine or the top part of the pelvis, to where the femoral heads are, it's called a femoral bisector line, and then all the way up to the top part of the spine. And if that number, which here it's 37, that number's anywhere above 30, I start getting really concerned. Average is 13. And this doesn't change if you're leaning on a walker, if you're laying down. This is a sign of a spine that's been decompensated or the translation. And if you look right here, she actually had screws that broke and this slipped forward. And so this area did not heal. And because you have a centimeter of slippage and you have some degeneration and an extra kind of curvature in the thoracic region, well, the alignment's off. And so with her, I did what's called an ALIF, and that's fairly minimally invasive surgery. I'm going through the belly, and it sounds scary that you have to go through the belly, but I'm able to put a triangular graft in to really get the shoulders back over the pelvis. I'm also able to do it with very minimal blood loss, and it's a fairly safe surgery, but going through the abdomen requires that I need a general surgeon or a vascular surgeon. And so when we look at it though, now I have her within 10 degrees of normal, and it's a bigger surgery, but she had, and this part I can't say is minimally invasive. I cannot do this through small incisions. Going through her abdomen though allowed me to get this cage in here, and then allowing the rods and screws allowed me to pull this bone back and get her back into normal alignment. She's in Arizona and she's doing great, and she's gone on to fuse this level. Long term, I get really concerned anytime with a fusion, the level above. And so that's something where I'll kick it back to the therapist to talk about how to maintain alignment after we got it dialed in the surgery.
Right, so after a fusion, right, that spine is locked. And so we have to get stability, but also mobility from somewhere. And so the body is sneaky and it can compensate all the time. And so typically right above where there's no movement, we tend to see instability start to be created, again, based on poor movement strategies, overload of tissues. And so again, it's kind of going back to postural training and core basics to help prevent further need for surgery in the future.
So this is another case presentation, and the concerns on this one, and also we'll have you draw your attention to this hemisphere, this ball right here. It's a metallic ball, it's a calibration device. In my training, one of the other things we did was use custom rods. And so a screw is a screw, but each one of our spines is different. And I don't know if most of us know, but in spine surgery for years, we would bend our rods. And if you had 10 surgeons line up and you told them to each bend a rod to 30 degrees, you would get variations with every single rod. And it's important that it's also an art. And there's a lot of surgeons that are very, very good at it. But how do you close the gap on the last few degrees to try to get perfection and try to get reliability? And that's with pre-op planning and templating. And so when I look at this patient, I make all my measurements, and then I'm able to have a rod that's manufactured specifically to your spine. And it gives me a good template intraoperatively. Did I achieve what I was going for, first of all? And second of all, I know for a fact that there's been no kinks or bends, and so that rod is actually stronger. And so I am a big believer in that technology. It's not something I do often. For a small 2-3 level fusion, I probably would not use that technology. For a bigger construct though, I don't want to have to come back. I want to limit the rate of rod breakage. I want to limit the rate of proximal junctional kyphosis, where the top part of that tilts over and wears out. And so that's what that middle ball is. But this gal had rheumatoid arthritis, had a significant lumbar degenerative scoliosis. You can see this curve coming off. You can see there's a shoulder asymmetry, and there's actually a little bit of hip asymmetry. And so her overall alignment though wasn't bad. Meaning that when I looked at her from the side, she was actually a little less than 13. And so my whole goal for surgery was to not overcorrect her. And I don't want to make her even more leaning back. And if I did that, she's then going to want to lean forward, which then increases her rate of having problems. And so this was that custom rod, and as you can see, they're symmetric. They're, you can almost, from this x-ray on the right-hand side, it's called a lateral view, you can see that her number went from 8 to 9, and you can see that we were able to get everything right where we wanted it and to maintain her alignment, and her spine is straight. Her shoulders are level. And so it's really important to try to really have ability intraoperatively to achieve the outcome that you're going for. And I will talk about one more treatment option, and then we'll probably open it up to questions to the therapist or myself. And that's what's called an X-lift. And there's a lot of different names for it. There's D-lift, there's X-lift, there's L-lift. It all means coming from your side. And that could be side at the lumbar level or at the thoracic level. And the advantages of that is I'm able to get a very similar cage like I get from the front belly from side to side on the vertebrae, and I can increase fusion rates, I can correct scoliosis, I can correct instability or slippage, and it's done through a very small incision. And the reason this was made available is because of the device over here, and this is called neuromonitoring. And what this allows me to do is during the surgery, I know exactly where your nerves are, and I know exactly how close I am to them. In front, this is what scares me and the general surgeons, is some of the largest blood vessels in the body. And so I want to be as close to these nerves and as far away from these structures so that I can put a very nice graft in to elevate that space that's been shrunken down over years and to decompress those nerves. And then I'm able to put the patient on their belly and through very small incisions put screws in. I don't have to make a big incision. I don't have to have the blood loss or the pain that's commonly experienced after big lumbar surgery. And then indications. So the instability, which is where one vertebrae slips on top of another, is called a spondylolisthesis. We talked about deformity, which is that scoliosis or they're leaning too far forward. Degenerative discs. So if their discs have worn out at multiple levels, this is one of the options. That nerve that has to leave the spine goes through a hole, and that's the foramen. So you get foraminal stenosis. It can be treated that way. Adjacent segment disease. So if someone had a fusion, let's say 10 years ago, and that level above broke down, I don't necessarily need to open them all the way back up. A lot of times I can put this cage in, lock that next level down, and they can go home either that day or the next. And revision posterior. So this is if someone did not fuse, like that gal, the first case I showed, where she broke the screw and slipped forward. Well, you can use these cages for that as well. Corpectomies is where I take out the front part of the vertebrae, and so you can use that as well. And so, patients that can't have the surgery. If you ever see this, I have 3 kiddos and they love Disneyland. It's actually in the literature called Mickey Mouse ears. And so what this means is that the psoas, which the therapist, I will kick it off back to them and tell them how important that muscle group is, but the psoas muscle carries all of the nerves that run out of the lumbar spine down to the legs. And if this muscle is in front of the vertebrae, then I cannot safely get a cage in because these nerves are too far forward and there's not enough space from where this big blood vessel is to where the nerves are. So patients that come in are like, oh, I want that XLIF procedure. And I see this anatomy and I tell them, I'm sorry, it's not safe. It's not something I can safely do. And so that's where I'd have to do the more tried and true open surgical procedure. So let's talk about the psoas.
Psoas, no, that's a great muscle to talk about. So yes, going into the psoas, that is a muscle in our hip actually. It's deep in. If I was to be palpating on you guys, it would be kind of inside the hip. It runs up and connects to the spine. And it is a very important stabilizer of our hip, but it also can become dysfunctional pretty easily too. It can lead to a lot of problems through the hip area, including pain, drawing the femur forward, non-optimal alignment, same kind of thing, just different joint that we're talking about. But we want to make sure that that psoas is actually working together with the other core muscles so that we maintain that optimal alignment. It can become really, really tight. Our society, we sit. So we are in a more flexed position through our hip. That muscle can become dysfunctional in that pattern. So we have to kind of find out what's going on. A lot of people will come in with back pain, and it actually might be coming from their hip because that psoas is too tight or it's not correctly firing. It might also just be more of a secondary result of something else that's going on in the back pain. So we are going to obviously be looking at what's happening through the hip and pelvis as well as glutes. But the psoas is a very important muscle that can become dysfunctional easily without people knowing it, and it can actually be a pretty painful muscle to work on. People will say, you know, there's something wrong in my belly, that's what's going on. It's not musculoskeletal, and it's actually their psoas is very tight, and that's the referral pain they're getting is somewhere else into the pelvis.
And one of my favorite things to offer patients, and it's usually not even something that's currently affecting them, but if you get a psoas muscle spasm, again, all those nerves that run down your leg have to run through that muscle. And if that muscle spasms, you're going to get locked over and bent forward, and you're not going to want to get out of bed, you're not going to want to move. I mean, it is very, very painful. So having muscle relaxers, and usually anti-inflammatories and muscle relaxers are the two kind of mainstays in my initial phase of treatment. And the reason why is the muscle relaxers, they can make you sleepy, they're not something I want you to take all the time, but if you happen to be on vacation or if you happen to be there on the weekend, there's no one available in your primary care office or the orthopedic office, well, you have that medication to at least give you some relief. And that's one of the only things that can help. Pain meds don't usually help. Stretching is very painful, and so a lot of the things we try to do, usually it's tough to break that cycle, and so I think muscle relaxers are really important. So contraindications to this procedure is the lowest level down. I can't do it because the hip bone is in the way. If you feel your hip bones on the side, those are your iliac crests. Well, they ride up to about the L5 or even a little higher. And so I can't get around that hip bone. And so at the L5-S1 level, I'm either putting a cage in from the back or from the front. 4-5, if the hip bone is too high or they have an abnormal number of vertebrae in their anatomy, is what we call transitional. And that's about 10% of the population that either has an L4 or an L6 vertebrae, so they're one less or one too many. And so that can also affect the anatomy. If you've had prior abdominal surgery, that sometimes limits us. Prior radiation, where the vascular structures are. We talked about the Mickey Mouse ears. They have really severe narrowing, and I'm relying on what's called that indirect decompression, so that car tire that bulged out, if I put a spacer in and I pull it back, that car tire sucks back in. It's like filling it with air. Well, if the area is so tight around the nerves, I can't rely that I'm going to get enough of that kind of car tire analogy to suck back to make enough room. And so that's usually when I'll have to actually remove bone and turn a regular car into a convertible. High-grade spondylolisthesis, so if the vertebrae's almost fallen off the front, this isn't a surgery for that. Severe osteoporosis, I'm a really big fan on bone health. And as an orthopedic surgeon by training, this is a big issue, and almost all of us are going to deal with it. We're in North America on the northern aspect of it, so we get less sun exposure in the wintertime. And as we age with the hormones, testosterone, estrogen, our bone quality decreases. And so, really everyone in this room should be on vitamin D. And vitamin D also prevents fractures, but it's not because necessarily the bone's stronger. Vitamin D not only helps with bone health, but it also helps with nerve health. And there's a lot of studies that have gone on that if your nerves fire quicker, you can catch yourself and prevent that fall from ever happening. And so that's the reason why there's less fractures when we take vitamin D. And so it's really important from that standpoint. So getting a DEXA scan, which is a bone density scan, will tell me how strong your bones are. And if I'm having to put this cage all the way across these vertebrae from the side and something that's been collapsed for years and then bring it back up, I need to make sure your bone can tolerate that. And so that's why it's important to get a bone density scan. Complications, with any surgery you can get infection, blood loss, because those vessels are in front, it's scary. If you use the monitoring and you use your x-rays and you know exactly where you are, it's not going to happen. I haven't had this happen, but it is in the literature. Damage to the spinal cord or peripheral nerves, blood clots, injury to those nerves can cause loss of sensation or motor function. Impotence is a very rare occurrence in men, but it is something that can happen. And then permanent pain and or deformity. And so we have to talk about the good and the bad. When we talk about the good though, we look at what a traditional posterior fusion time looks like, and you're at the lower limit of normal when we compare surgical time. Blood loss is significantly less. Complication rates are significantly lower. Time to post-operative ambulation, where I'm walking them. I had an 80-year-old that I operated on a few months ago, and he wanted to go home that day. And I said, well, you have diabetes, I want to monitor your sugars, I want you to get some antibiotics, you're not going home today. But next morning, he's like, I'm going home today. And he was kicking butt. And it's a neat surgery, and it's neat to see patients being able to go home the same day. But on average, length of stay is about 1.6 days, compared to the more open, again, slightly more invasive surgery, which is 3.3 days. And so just one last case I'm going to present, and again, these are the different ways to use it. I'm not a big fan of using the plate because when we talk about the psoas, I'm going through that muscle, and I want to limit my time. And so really the clock, I'll have a timer on my wall during this surgery, and the second 30 minutes hits, if I'm still operating, I have to pull my retractor out. I don't want that muscle to feel that stretch for that long because it can get irritated. And so you can get patients that have degenerative disc disease, that's what that triple D stands for, or you can have that scoliosis. And so this is the last patient, and she has vertebrae that's like a house that's built on sand. They're slipping all over the place. This vertebrae is sliding off to the side. This vertebrae we have what's called asymmetric collapse. This one is bone on bone. This one's bone on bone. And so, she's had 2 prior total hip arthroplasties. And in this case, she was a perfect candidate. I needed to improve her alignment from the side, so I already knew I wanted to go through the belly and do what's called an A-lift. And then I was wanting to do several small little flank incisions to do the X-lift procedure, all through very small incisions, and then flipped her onto her belly, and I was able to put all her screws in through about 1 centimeter incisions. I didn't have to remove any muscle, I didn't have to dissect any tissues. It was all implants that were placed with X-ray and using that neural monitoring that I had mentioned. And so here's where her outcome is. So her shoulders are level, her spine is now straight. All that slippage that had occurred is now gone. These are called iliac screws, and it's important fixating into the pelvis, but it's neat because for years we were never able to put these in what's called percutaneously, and that's with X-ray, putting a screw in over a wire. And I think it's a really neat surgery. I think it's a game changer. During my fellowship at Duke, I spent a lot of time, I specifically went there to learn this procedure. I think it's a pretty fascinating surgery. And so again, now she's within 10 degrees of that normal. And I think it's really important to being able to get patients now back to a more normal alignment. I don't need to make them perfect, and the older the patient, I'm going to try less actually to make them perfect. Bringing someone from a 40 degrees to a 13 is not ideal. Again, they're not going to tolerate that much change. Those muscles have been in those positions for so long. And so to kick it back to our therapist. And post-operative care, one of my biggest things is stretching. And so,
Sure. Yeah, so kind of mentioning before, the ACSM standpoint is 2 to 3 days. Certainly post-operative, that's going to be different, but stretching can happen again in different ways. So there's static stretching, just holding a position. Ideally, like up to a 30-second window is a good time frame to cause that elastic effect. You can do dynamic stretching, again, pain-free movement, but moving your body through a range of motion to kind of get that soft tissue to bend and move as you're getting a stretch. And then also, we say ballistic or kind of a bouncing or an oscillatory type stretch. So we provide stretches, we provide pictures for stretches, make sure people aren't stretching to the point of pain, because that's not helpful, but so that you get slight discomfort, so you're getting some consistent and lengthening of your tissues post-operatively.
and so that was the presentation from my standpoint. Is there other things you want to mention or
No,
discuss?
I think that was good. It was nice for us to hear too, how much technology has changed and allows them to do this amazing job as small and minimally invasive as they can. And then it allows us to do our job too a little bit easier because the muscles aren't really being disrupted nearly as much as they used to. And so it's just, we wanted to show you guys that there is still life out there, and even if there's back pain present, that fear, anxiety that is totally normal when we have pain, there's options. There's things that can be done preventatively, hopefully is the best, but if it's not preventative, there's things that can be done. So we would love to open up for questions. We'll go in the back.
This is a very simple, I'm very impressed by the sophistication of the whole presentation, but very simple question, I hope. I'm here to advocate for an 84-year-old woman who is just she's at the point where getting in and out of bed, from lying to sitting, and then, or from sitting to lying, she can't keep a neutral spine. And I'm sure that happens to a lot of people, and I think I know what she needs to do, but she doesn't have the strength to do it, to keep it neutral, which is to get her legs up at the same time as she lays down. I'm wondering if you have a good suggestion for doing that.
I'm assuming you guys are probably already doing the log roll technique, which is going to put the least amount, but that's probably challenging with the strength factor to get
After
the
the fact.
So
log rolling is fine. After she's got her legs up.
it's the actual
bed.
swooping off the bed.
It's getting the legs off onto the bed and down
Okay.
also, but especially up.
Yeah. A lower bed can be easier for or a bed that is adjustable. I mean, I know that not everybody has the means to be able to do that, but that could be something that could facilitate as far as getting on. If it's lower, it's not as much of a lift, load to the tissues. Or even if it's an adjustable bed where the head can kind of come up to help push off, that might be an option. Honestly, getting into therapy where we can repetitively do things, we can put, and even if she's not able to come out of the home health can work on this too. They can look at pillow placement. Sometimes it's people can't do it and their legs, one leg comes off, keeping a pillow placed between to keep that spine. As they come up, it should be kind of a biomechanical thing. As we are bringing our legs off, our hips actually kind of start to rise. So teaching them those principles, sometimes it's just correcting a little thing. And it might just be having someone work with her a few times. That would probably be my best bet, not having seen. But yes, it can be sometimes really challenging to maintain that pressure. The other thing is just having her do a gentle, like she's drawing her belly button in, to give her a little extra stability. So that's going to almost form like a corset around her spine, so it gives her that more form closure through the pelvis to allow that stability as she's kind of shifting. So if there is any instability through the spine, that might help a little bit. And that's something normally people can follow pretty well. And it doesn't have to be as hard as possible. Actually, that can normally cause some pain. Really gentle, 25% effort. See if that would help.
And I would be concerned too, given that she's what sounds to be very deconditioned. What's the source of that? Is there nerve pathology, or is this due to pain and now these muscles have atrophied so much? And so if therapy's not helping, you may want to at least get an x-ray to see if there's something else going on, or an MRI. And that, again, is down the road, but 84, we do slow down. And surgery is not always the safest for an 84-year-old. And so again, it kind of goes back to that cost benefit where we have to realize, could we live in a wheelchair? And as sad as that may sound, that's actually sometimes the safest thing for some of my patients. And falls can be deadly. Hip fractures in an elderly patient, there's a fair amount of them that don't see the next Christmas. So.
What's the recommended dosage for vitamin D supplements?
So anywhere, it depends on if you're taking like vitamin D3, which is the most active form, but usually about 1,000 units is what we recommend. You can get a calcium and vitamin D combination. There's like Citracal, there's all these different types of medications. Your primary care doctor or myself or anyone in the community, a lot of it's over the counter, but really any is better than none. And sunlight, a lot of times we're putting on sunscreen because we're so concerned about sun cancer, or skin cancer, excuse me, but the issue there is you're not getting vitamin D through the absorption of the sun. And so even just 5 to 10 minutes a day of your arms and face, not in some type of window that prevents UV radiation, but you want to just get some sun exposure, and that's really important on top of the vitamin D. That gentleman had his hand up first. Yes?
Is there any muscle reduction over the counter?
Not that I'm aware of. And so,
You said, like over the weekend, did it, where?
so when patients come see me, I'll prescribe it, and they're like, no, I don't need it, I've never had muscle spasms. And it's something I prescribe almost to every patient to have it for a rainy day. And so there's Flexeril, or also the same name as cyclobenzaprine. And there's Robaxin is another one, and that's methylcarbinol is another name for it. But those are the two I like to use most. If we're concerned about the sleep-provoking nature of Flexeril, I'll usually use Robaxin. It doesn't make you as sleepy if you had to use it during the day.
One more good question. I had to give the microdissectomy about over 10 years ago.
Mm-hmm.
At that time, they only called it dissectomy. It was okay, but we had lots of tingling. I had lots of tingling in the shin area. Reason for that, and also I was told if I'm patient, this might go away.
So,
Could you elaborate on that?
my first response you may not like. And that is when patients come in, I put actually very little stock in the sensory component. So if patients have tingling, I can't tell if that's peripheral neuropathy. I can't tell if that's someone that's had chronic nerve damage and it's not going to get better. Or I can't tell if that's acute. And so I get really concerned about shooting electrical leg pain. But if someone has numbness or tingling, it's really tough to tell unless I'm doing what's called an EMG nerve conduction study. That's where I'm putting electrodes into your legs, and it's kind of uncomfortable. And I definitely don't order on everyone because sensation in itself, unless you have a completely numb bottom of your foot and you're stepping on sharp objects and getting infections, and that's something we get concerned with diabetics. But sensation, I get more concerned about weakness. Because if you had weakness, you're a fall risk. And so sensation, I tell my patients that it should get better within 1 to 2 years. It takes that long for a nerve to regenerate. And if the nerve doesn't regenerate so that all the sensation is perfect, then at the 2-year mark, I would usually tell my patients, it looks like this is something we're probably going to be living with. It's going to be uncomfortable. There's some nerve medications that we can provide, but I'm really concerned if you have any weakness. If you didn't have any weakness, I would say it was a successful surgery.
That's exactly what happened. About 3 years.
And the longer the symptoms, like I mentioned with microdiscectomies, the longer the symptoms are present, the less likely for a full recovery, and the older the patient. And so just things to consider. Yes, sir.
What are the most effective exercise devices to use?
Devices.
You mean at the gym?
Well, you
Or-
see all these advertisements on
Ah.
TV, and I don't know which one to buy.
Honestly, where I would start is good old movement. Going to the gym and getting on the machines that maybe don't load you as much, like at the Ridge, the new step machines, the recumbent bike, things that are not going to have that repetitive trauma at the beginning, especially if you don't know how to handle the load or things like that. I would start there. All gyms, if you're looking at a gym, it's specifically, they normally start with a trainer. You can start there to kind of show you the rounds. And I always tell people to start slow. As far as devices you can buy on infomercials and things like that, I think there's always going to be the next gadget out there. But paying attention to your pain, like he said, if something is causing pain, you're not going to want to keep doing that exercise. Now, there's a difference between, wow, I just worked muscles kind of pain, and then your pain, and everyone knows their pain the best. And so paying attention to that, you know, is it causing pain during it and it's lasting for days? That's not what we want. Is it, oh my gosh, I worked out and then maybe that night I'm a little muscle sore? That's pretty normal as long as it's not happening over and over and over. But as far as one specific exercise machine, it's kind of geared to what you're looking for. And I honestly think, just even as that study showed, using body weight supported, you know, simple modified squats, things like that can show benefit. You don't necessarily have to have the niftiest gadget out there.
And walking versus jogging?
I think walking, if you've been a jogger your whole life, that's a different thing. Keep doing it. And I think if you want to get into jogging, that's depending on age and what's going on, dysfunction, that's fine. But I always tell people start with walking. Get your cardiovascular up. You can always start into if running is appropriate, you can start into a walk-run program. And again, build up that tolerance. That whole idea of our body's used to the stressors we place on it. If we have not ran and we go out and run 2 miles, likely your tissues are going to tell you they don't like it. And so as we gradually build up into things, we're having less likely for that injury or tissue damage. Yes?
The step from going to spinal shots to even the low invasive surgery is pretty huge. So if you can control your pain by a spinal shot, when do you make the decision whether to go to the next step? If you're getting more than one a year, one every 6 months, one every 3 months, in general?
Great question. So the first thing I'll ask my patients when they have injections is, did it help? Because as long as it helped, that gives me valuable information to at least know that I have the ability to turn off this pain. And so that's the first thing. So if injections aren't working at all, continuing them is pointless. And then we get into a point where if you're not having weakness, you're not having bowel bladder problems, you're not having balance or coordination issues, it comes down to a quality of life that I can't answer for you. I can present the options to you. I can tell you, well, if the injection's only working now 2 weeks, we can do another one in 3 months. So, you know, a short period of the next wave, you're going to be able to control your pain. And you may say, I don't want to do that. I'm not hunting, I'm not fishing. My quality of life has gone down the tube. I've really seen this decline over the past 2 years or 2 months. And so, you know, that's where we look. Have you done therapy? Have you done the medications? Have you modified your lifestyle? Have you tried the injections? If you've done everything, then there's this fork in the road. And we just want to go down eyes wide open, you know, with both roads. And if we don't operate, we're kind of accepting that things could get worse, and we may not be able to get back to that. And so sometimes timing is really important.
Is there any maximum to the number of injections that you can get in a given year
It depends on the type of injection and the location of the injection. And so when we talk about the spine, if I'm giving the exact same injection in the exact same spot, I don't really want more than 3 and at most 4 in a year. But now I can write for injections, and I did training in them, but my partner, and we have folks in town, Dr. Stark and Dr. Ayler and then Dr. Slocum, there's 3 folks in town that do injections. And so we can inject the joint. We can inject where the nerve is. We can inject where all the nerves are. And we can also inject the nerve that goes to the joint. And if that turns off your pain and it's all coming from this angry arthritic joint, well then you don't need surgery. I can do a procedure where we kind of burn that nerve, and the only function of that nerve is to tell your brain, hey, my back has arthritis. You turn that switch off, it regrows in about 9 months. You may need to do it again, but that's way safer than surgery. And so that's an option too. But it really comes down to quality of life, to answer your question.
Thank you.
Is the only way to fix those with screws and...
Depends on your problem. So if we're doing a fusion, the way that we get bones to knit together is basically by doing this internal brace. and that's with the screws and the rods. Now having this cage is really, really important because that cage is angulated. It has a lordotic angle in it. It's not just a flat parallel cage, and so it's able to correct alignment. So it depends on, is your alignment normal? If your alignment's normal, maybe we don't need to do as much surgery. But it all depends on what your problem is, and if it's something that requires a fusion, well, there's a lot of times where a fusion makes a lot more sense than a decompression surgery.
Okay, one more question. So will I be 5'8½"?
You wouldn't be the first one.
5'6"?
You wouldn't be the first one to ask. So it depends on how many levels, but usually we're creating about 5 to 6 millimeters of height when I put one of those cages in. So if you're bone on bone, I'm putting either a 6 millimeter or an 8 millimeter cage in, and so you do that several levels, you may get a half inch or an inch. More importantly, if you're going from this alignment to this alignment, that's where you're really going to notice that you're able to look people in the eye and your actual, your eyes are on the horizon, which is really important. You're expending less energy when you move around. Yes, sir.
I was curious about inversion and dry needling.
I'll answer inversion if you guys want inversion tables, and then dry needling. So inversion tables, I think, are something that if you want to invest in, it is a device that can help alleviate the symptoms while you're in it. It really doesn't do anything because once you get out of it, gravity hunkers back down and you're instantly back to the same amount of pain because that hole where that nerve leaves, if you go in an inversion table, well, now it opens back up. The second you're out of it, it closes right back down. Now it gives me valuable information though because it tells me that your narrowing or the stenosis is dynamic, meaning it's a moving target. Now if the inversion tables stop working, that tells me that it's static stenosis, and that now we're talking about that this isn't going to get better with exercises or with further therapy. I'm really concerned that your amount of narrowing has gotten so severe that even with traction and movement, you're not getting better. So that's my view on inversion tables.
I do agree, actually. So trigger point dry needling is a modality we can use for manual therapy. It is basically a release of a trigger point or a taut band of muscle using a small monofilament needle. And basically what it does is it kind of resets the muscle. It creates this muscular twitch when it happens. And it's in turn, in theory, is supposed to kind of reset that muscle. It can be very beneficial, I think, as a tool for manual therapy. However, I think with like any tool, if you're having to use it over and over, we're not addressing the real problem. And so that's where I always like to tell people, okay, we can use this. This can be really, really beneficial to release the muscle so we can start getting you moving through a range of motion correctly. But if we're going back to this every single time, there's something else that we need to be looking at that we're not addressing. And so it's a great tool, but I think it's not something we can hang our hat on like any modality or any type of treatment. We can't just hang our hat on it.
Okay, so the dreaded, what about the Laser Spine Institute commercials we all see on TV? What's your take on that sort of?
I get the question very often. And so there's some phenomenal surgeons that work within the Laser Spine Institute. I have two issues. Is first of all, it's a phenomenal marketing campaign. And you kind of need to question why do they need to market it if what they're doing is so great. Mayo Clinic, I'm not really seeing commercials for Mayo Clinic, but everyone knows about it. It's because of the quality they provide. But if I have to keep spending millions and millions and millions of dollars to promote Laser Spine Institute, well, why do they need to do that? And so my concern is the fact that it is a little bit of a marketing ploy. And the laser is fairly gimmicky, meaning they have it in the facility, but what is the laser doing? It's not doing fusion. It can sometimes shrink a little bit of a disc, but you still have to do the surgery to get down there. It's still surgery. When I do that micro disc, it's the same incision. There's no difference when we get down. The disc needs to be taken out. The nerve needs to be decompressed. The laser has nothing to do with that. The problem I've had with a lot of my patients is they get this idea that, oh, free MRI review. Okay, so I go down there. I get this free MRI review. And then they'll review it, and then they'll say, okay, well, here's surgery that we think you need. And then they're referred to another doctor. And the doctor then meets them and go, you're not a candidate for that surgery. And so I've had several patients that go down there with the assumption of getting a disc replacement or some other type of minimally invasive surgery, and then it's luckily they're at least caught and they don't get operated on with the wrong surgery, but then they're now being forced, well, I thought I was going to get a disc replacement, now they're telling me I need a 3-level fusion. What do? I'm now down in Arizona, and I now have to go, if I have surgery, I don't have a doctor now that's aware of what's going on, and now I'm coming back to Bozeman, and I'm happy to take care of anyone that has surgery anywhere. It's not an ego thing, but it's a little bit of an issue when these patients are then forced to make a very tough decision that they weren't aware of. And so I think having that rapport, having that FaceTime, having to know that doctor on multiple occasions, everyone's on the same page, is really important. And I don't think you get that with laser spine.
Okay.
This is kind of old school, but I'm just curious, is traction ever appropriate for any of these patients?
Well, the inversion table and traction I would put in the same category. And what you're doing is you're trying to basically recreate what your body was 5, 10, 20, 30 years ago before those discs lost the water content that was in them. And that's natural history of a degenerative disc problem. All of us will have water slowly leave the shock absorber part of our spine. And so traction or inversion tables, what you're doing is you're creating some of that space that you used to have for those nerves. Problem is, the second you come out of that traction, you lose the benefit from it. Unless you want to walk around with a halo, holding it up.
And I think there's things that, can facilitate that feeling of that traction. So aquatic therapy is actually a great thing to get the tissues unloaded. The buoyancy of the water kind of naturally tractions the spine, so it feels good to do more exercise in it. And when someone's really acute, I might even teach them to lay down with their legs up on like a bolster or something. Again, it just unloads the spine. But like he's saying, it's going to go back, but if we can, in those acute situations, it might be something that's beneficial. But necessarily like traction tables, I don't even think there's one in this town anymore. Yes?
Sleep aids, like my pillow. Not about marketing,
Yeah,
but I mean, we spend 1/3 of our life in bed.
it's true.
So,
I get this question a lot, and it's interesting because I agree with you. 1/3 of our life. So the quality of your mattress, I think, is incredibly important. I have 0 stock in Sleep Number. I was flabbergasted when I saw this air mattress get built in my room, and it looked like it was not worth the amount of money I spent. But I think for me at least, I'm able to change the density. And so for years, my wife and I had the same mattress. I'm twice the size. Why should we have the same density in a mattress when I'm twice the density? She might say that's up here, but and so with a Sleep Number, your spouse can have one certain amount of density, you can have another. And the other interesting thing about it is it actually gives you critical feedback every night. Lets you know how long you slept, how often you were moving, what your heart rate was, what your respiratory rate was. And so you get this very vital information. And so I felt that it's helped me, and I got that when I moved out here. And I've had some back issues myself, and so that's helped. But sleep aids, I don't know if you're talking about medication or you're...
Physical,
Okay.
like this My Pillow thing.
Yep.
Just for the record, I have a My Pillow and my neck has not been out since last year. I know it sounds silly and gimmicky, but I always had neck problems, and I go...
If something works, it works.
It works.
And if it's a placebo, if it's something that you're also focusing that, hey, I spent money on this, I'm going to be a little healthier, and it's a kind of lifestyle change you've made, 100% all for it.
I know, it's weird.
So we want to actually just thank you all for coming. We're going to kind of let those that want to leave. We'll be happy to stay up here for more questioning if needed. But thank you so much for your time, and take that handout if you learned something, and have a good evening.